Good morning, good afternoon, and welcome. My name is Ryan Toney. I'm a Learning and Development Specialist with the READY Initiative, and I'm pleased to welcome you to this morning's webinar on the recently released Guidance for Alternative Care Provision During COVID-19, coordinated by the Better Care Network, Save the Children, the Alliance for Child Protection in Humanitarian Action, and UNICEF. This session, which is designed for health practitioners, will introduce the guidance and help practitioners to understand their role in preventing family separation and supporting unaccompanied and separated children. Please note that there will not be a dedicated Q&A during this session, so we do encourage you to put any questions you have for our speakers into the chat box, and they'll do their best to answer them during the session. For more information on this and future webinars, please visit our website at www.ready-initiative.org. I'm now pleased to present the facilitators for this seminar, both from Save the Children, Senior Humanitarian Child Protection Specialist, Lori Murray, and Senior Child Protection Advisor, Becky Smith. Welcome to you both.
Thank you.
Great, thanks so much, Ryan. And thanks everyone for joining today. We're really thrilled to be able to present on these guidelines and really pull out the relevance and the specification for health practitioners. If I could ask you to put in the chat box your name and the country you work in and your role, that would be great just for us to have a bit of an understanding of who's here today. Ryan, if you wouldn't mind moving to the next slide. Great, and we can go right onto the agenda. Thanks. So what we're looking at today is we're going to give a brief introduction to the guidance itself. And how it was developed. And then we're going to look at key considerations for health practitioners. So this includes looking at the role of health practitioners in preventing family separation, the role of health practitioners in promoting family-based care, and then what to do in kind of these real scenarios where we have children potentially coming to residential care centers, and this includes quarantine centers and isolation and treatment centers. And so with that, I will hand over to Becky. Becky, you're on mute.
Sorry. Next slide, Ryan. Great. So today we're going to be speaking more in depth.
Oh, Becky, it seems to have gone on mute again. Still on mute. No. There we go. Now we can. Oh, no, we still can't. Sorry. Yes, now we can. Yeah.
Okay. I think there's a problem with my headset. If I need to, I'll take it off, but let's see if this works. Okay, so sorry. So today we're going to be speaking more in depth about the guidance for alternative care provision during COVID-19. This supports the initial technical note that we wrote on protecting children during COVID-19. And one of the reasons that we all came together to do this was because we recognized that we needed more of a how-to guidance about how to make challenging decisions about children's care in the context of infectious disease provision. Decades of research has shown that the family is the most protective environment for children, especially young children. And yet, during COVID-19, government ministries, NGOs, and national coalitions were really struggling with this challenge of, on the one hand, stopping the spread of the virus, while also protecting the most vulnerable and keeping children together. This document provides practical guidance to humanitarian and development context on the adaptations and the considerations needed to support children who are either currently in alternative care or going into alternative care placement during the COVID-19 pandemic. Can you go to the next slide, please? Nope. Sorry, that's one too many. Go back one. Yeah, perfect. So we're building on, in writing this, we built on an interagency collaboration, which we'd previously done for the UN General Assembly resolution on the rights of the child, focused on alternative care, and worked very closely with humanitarian actors like the Alliance for Child Protection and Humanitarian Action. given the unique nature of COVID-19 affecting so many countries simultaneously, we wanted to make sure this guidance was equally useful in all contexts, which did prove challenging, but we wanted it to be useful in high-income, middle-income, and low-income countries, and development and humanitarian contexts. So the first part of this guidance is talking about understanding the context that you're working in, because obviously there is a challenge in trying to decide what you're going to do, what the role of the government is in your context, what are the laws and legislation around alternative care, and then how you proceed from there. We're also going to be talking about ensuring appropriate care during COVID-19. I'm going to talk a little bit more about preventing family separation and supporting system-level response and gatekeeping. Now, for many of you, for child protection actors, gatekeeping is a term that we're fairly familiar with. But for those of you that are less familiar with it, gatekeeping is really a systematic procedure that makes sure that alternative care for children is only used when necessary and that the child receives the most suitable support for their individual needs. And we'll talk about how that decision-making process happens. But if you think of the word gatekeeping, it's kind of like a door that doesn't open unless a child needs to be placed there. Oftentimes we find that children are placed in residential care or placed with another family where there hasn't been a systematic assessment first. So therefore we don't know if that's the best place for the child. We don't know if the child needs to be separated from his or her family. So that's what we're talking about when we're talking about gatekeeping. And then we're going to talk about key considerations for placement in the different forms of alternative care that are often found. Next slide, and I'll hand over to Lori.
Great, thanks so much. So what we're going to ask is if you can please go to menti.com on your browser or on your phone and type in this code, which is 4584120. And to maybe make it a bit easier, you can also just click on the link in the chat box. And you should be able to meet there. So this is just for us to understand a bit more about those on the call and what your interaction has been in the past with some child protection concerns. So you'll see that the first question, if you manage to get on, yep, that's great. I see people are already joining. If you're having trouble joining, you can click the link in the chat box and it should automatically take you there. So the first question we have is, I have encountered an unaccompanied child in my work. So this is asking if in your current role or in your previous role, have you worked with a child who's come in either on their own or they've been brought in by someone who they don't know, maybe you know, in the case of Bangladesh, we've seen when refugees were fleeing from Myanmar, people would pick up children along the way and bring them to health centers on the other side in Cox's Bazar. And if anyone's having trouble accessing the Menti, do let us know in the chat box and we can try to provide some assistance. Great, I see we're getting a bit a range of responses, with most people saying yes. Okay, great. So I see that most people have actually encountered an unaccompanied child in your work, and I hope that then this will be a relevant webinar for you to maybe reflect on kind of what you did in that circumstance and what could be done in the future. I see a couple of colleagues haven't encountered a child and one is not sure, and that could be because we're not necessarily clear on the definition of an unaccompanied child. And we could say that there is some confusion around kind of these different terms we use, if it's an orphan or an unaccompanied child or a separated child, etc. Great, so if you stay on that link, a new question should pop up now. And this question is, in my work, I have worried about who is caring for the children of caregivers who are admitted. So this question is saying, a caregiver comes, maybe a mother, a father, a parent, aunt or uncle, they come and they need to be admitted into a clinic. or a health facility, and your worry is who's going to take care of the children at home, and have we considered this? Great. I see the majority are saying yes, this has been a worry in the past. Great. Okay, so the overwhelming majority really saying, yes, this is something we've worried about in the past, and maybe not known what to do, or maybe you have known what to do and you've contacted child protection colleagues or services. That's great. So we will cover this today on kind of what do we need to consider if a caregiver comes and we're worried about who's taking care of the children at home, or we just need to discuss it with them. Great, and we'll go on to the next question. So this question says, the context I work in has clear guidelines for how to prevent family separation. And I see that a few colleagues on the call are global level colleagues. So just pick a context or a country that you work most frequently with. And yeah, maybe it is that they do have guidelines, but you're not aware of them, and that would be absolutely fine. We see that happen a lot. Okay, great. We're seeing quite a wide range of responses. Yeah, with most people not being sure if they actually are guidance. Great. Okay, fantastic. And then we'll go on to our last question. So in your role, do you see yourself as a key actor in promoting child protection? And you might say, yes, I am a key actor. No, this is not something I really need to worry about in my role. It's not my focus. Or maybe I don't know. I don't know what it actually means to be a key actor in child protection. Great. Okay, wonderful. I'm very, very happy to see that no one said no. And that's fantastic. So what we'll do with the remainder of this hour is to look at our roles and responsibilities. No matter kind of what your role is, how do you promote child protection, and what are the red flags to look out for? And with that, we will go back to the PowerPoint. And I will hand over to Becky to talk about preventing family separation.
So within our guidance is geared for child protection teams, but it's also very relevant for health practitioners. So what we've pulled out is some of the key considerations for health practitioners to help prevent family separation. And we're not going to go into it too much in depth today as to why separating a child from his or her family is so fundamental, but there is a lot of research that shows that children who are able to have a primary caregiver, especially in the first 3 years of their life, are really do much better in terms of being able to form attachments and to survive and thrive. So there's a lot more evidence around that. If you're interested, we can certainly send you more information. Next slide, please. So what can health practitioners do to prevent family separation? Can you just pull up some of the areas? Yeah, so all efforts really should be made to prevent the separation from children from their caregivers. We know that sometimes it may be necessary, especially if there are significant protection concerns, or you're really worried about the health and safety of a caregiver. But the first and foremost you should be thinking is, how can I help support that family to care for the child? Social workers and caseworkers do need to be classified as providing an essential service and provided with the appropriate PPE to do that safely. And community health workers and social workers, you do have a real sense of what vulnerable family members are you working with. And we're recommending that community health workers should talk with vulnerable families to discuss what should happen if a young child needs to be hospitalized, or what to do if they do have a significantly vulnerable family member in the household, how to who would look after the child if a family member was quarantined or sent to a hospital. And I know that some of these discussions can be challenging because you don't want to imply that something bad is going to happen, but it's also just about thinking through who else could care for the child if needed, even if it was temporary, and helping family members to start coming up with those ideas. If separation does occur, the health team needs to consider how the child can have contact to his or her family during that period of isolation. What you don't want is for a caregiver to come out of isolation and, not know where his or her child has ended up, or a child to be placed in a facility and have no contact to his or her family. Next slide, please. Yeah, sorry. I don't know that basically when we're making alternative care placements, what we do is we make decisions based on two main principles. So these are principles outlined in the guidelines for the alternative care of children, the UN guidelines, which supports the Convention on the Rights of the Child. And there are two main principles. And if you can just click. There's a principle of necessity and suitability. So basically, as a practitioner, what everyone should be asking themselves is this placement necessary for the child? Does the child need to live in a different family or different placement than they are already? Can the family provide support to the child? And are there specific considerations during COVID-19 to help make that placement safe for the family and for the child? And then questions of suitability. If the child absolutely does need a placement, then what is the most suitable placement for that child? And in the policymaker presentation, we're going to talk a little bit more about how we can think about those issues in the standard operating procedures to make sure those two questions happen both at a national and local level whenever a child or a family member is going into a hospital or a health facility, steps to take when a child has been exposed to symptoms or of the virus and requires isolation, and identifying key personnel, including caseworkers, that may be able to provide some care for that child if they do need to be separated. And yeah, if you can just click on the next points. So there are formal and informal alternative care placements. Some of them are through the government and some of them are just between family members. But regardless of whether or not they're formal or informal, they should be recorded and documented. And this is because we want to be able to follow up with what happened to the child, even if it's a community member following up with the family or a community social worker or community health worker, just to see if the child's needs are being met. Health staff should immediately report any unaccompanied children brought to their facility to the local government and or child protection workers. And so having those contacts and recognizing who the child protection teams are can really help to facilitate that rather than suddenly having a problem and not knowing who to contact. And remember that families will often make their own arrangements. And it's just trying to figure out, does the family have all of the information necessary to make those decisions? And how are they going to follow up with children after they've made those arrangements? Next slide, please. And so given the importance of family-based care, we have some general considerations. And when we're talking about family-based care, we're talking about children in their biological family, we're talking about children in their extended family, and we're also talking about foster care. Next slide, please. So some of the general considerations include ensuring community health workers alert child protection practitioners of any families where children may be currently unsafe, any families that have separated due to the pandemic or are at risk of separation, and ensure that caregivers visited by community health workers know who to contact if they have concerns about separation and the available supports in their areas. And supports can include cash assistance or livelihood support, parent and caregiver support, health services, just trying to link them to the existing services that are already there. Next slide. So the key considerations for family-based care placements: kinship care is the most commonly used form of care. It's family-based care within the child's extended family, with close friends, or with people who are known to the child. And foster care is family-based care provided to the child by someone outside the extended family, which is usually short-term. And either of these can be informal or formal, but we know that the most commonly used form of care is usually informal, between family members or relatives. So some of the considerations on these family-based care is to, can you keep going there? Always consider family-based care arrangements before residential care options. There are a variety of reasons for this, but also just in terms of COVID-19, the spread of infection in residential care facilities, as well as an additional risk. Have a plan for children to be reunited with his or her primary caregivers as soon as possible. Support caregivers in reducing the risk of transmission through providing PPE, daily supplies, and discussing ways for isolation. Again, trying to help family members to protect themselves or protect extremely vulnerable members of their family. Caregivers and children should know how to access support and report any concerns. And make sure that children and caregivers know if a child has an underlying condition that may make him or her more at risk. Okay, next slide. Logistical support. So this is just also making sure that there are logistical considerations about how there's going to be safe transport for a child that needs to be transferred to a relative's home. Phone credit or devices that allow for remote follow-up and support if needed, and contact with the child that needs to be isolated. Community messaging should encourage local officials and community groups to check on vulnerable families. And wherever possible, encourage kinship carers to bring the child to health providers and provide medical screening if a child has been exposed to COVID-19 safely. And encourage local community groups to set up a system, that I was just talking about, especially in terms of quarantine. And I'll hand over to Lori to talk about residential care.
Great, thanks, Becky. So as Becky mentioned, our priority is to always have children in family-based care, as this is kind of historically the most safe and protective environment for a child. That being said, we know that children at times might have to be separated from their family members and potentially go into residential care. Residential care here is quite a broad term. So residential care can refer to potentially orphanages or academic institutions where children are staying, or kind of specifically as it comes to the linkages with health, it might be quarantine centers or isolation treatment centers. And we've also got included there interim care centers, which might be a space where a child can come for a short period of time before they can go into family-based care. If we could please go to the next slide. So as Becky mentioned, residential care is more prone to cluster infection. So we hesitate to put children in residential care for protection reasons, but also for health reasons. And we know that in residential care, children are more likely to be at a higher risk of abuse, neglect, and exploitation. And this is especially true for children with disabilities and other vulnerable groups of children. So as much as possible, we need to ensure we've got the right safeguarding measures if this is the option that we're going to have to use for children. What we recommend and advocate for is that health care workers and different health facilities partner with residential care facilities. so this might be orphanages, to ensure that there's access to health services. There was a wide variety of responses to residential care when COVID-19 broke out. In some contexts, we saw that residential care facilities closed down and sent children home. In some contexts, we saw that they closed down and kept children and staff inside. And so we need to ensure that we've got the right health linkages, that if those children are remaining inside the care center, or even if they're returning home, that we're doing it in the safest way possible. And no matter what, if a child is in a isolation treatment center or a quarantine center alone, we want to ensure that they're able to still communicate with their family members. And this links to what Becky was saying before, ensuring that, you know, if a caregiver or a child comes out of a center, that they know where their family member is, and that they kind of have the logistical supports necessary. And this can often just be a matter of advocating for that. And we can move on, or we can click the next component. So just to say as well that these guidance and this guidance on residential care is complementary and builds on WHO's guidance on considerations for quarantine of individuals in the context of containment for coronavirus disease or COVID-19. And that serves as our overarching guidance, with this giving a bit of a deeper dive into alternative care. And you can move to the next slide. So the guidance has a table that looks at key actions we recommend for different scenarios a health actor might find themselves in. So in this scenario, we've assumed that an unaccompanied child has come into a quarantine center. So this could be a child who was with their family before, but now is alone, or potentially a child who's been living on the streets and has had to come into a quarantine center. We saw in some contexts that government officials went and kind of rounded up children living on the streets and put them in school buildings or something to have them stay in kind of one location. And it could also include maybe a child-headed household. So a child is 16 and caring for their siblings and they have to come to the center alone. So an unaccompanied child is someone who is not with anyone by law or custom who would care for them normally, joining them. So they're either coming alone or they're coming with someone who's potentially a stranger to them. So if we have an unaccompanied child in a quarantine center, we recommend that they stay for as short of a time as possible and is required by public health guidance. If possible, we want these children to be placed with known adults. So if that could be a neighbor or someone that they know potentially from a community group, religious group, whoever, just having a familiar face that can keep an eye on them as well. We advocate that unaccompanied children and siblings not be separated. So we want to ensure that siblings remain together. And we've seen different kind of practical and real life challenges. If we've got a quarantine center where they separate girls and boys or men and women, and you've got a brother and sister who really wish to stay together. And that just requires some advocacy to, depending on kind of the age and risks, to see if that's possible to keep them together, or at least to have them be communicating regularly. We say that children in these centers need to be cared for by dedicated and trained staff. And this is a point we highlight because in some contexts, we've seen quarantine centers be staffed by essentially just guards, and overnight having guards who sort of man the place and the area. But we want to ensure that staff actually know how to interact with children. They know what red flags to look out for, and that they're able to actually provide care for the children, not just provide sort of a guard or security service. And we advocate that children should be provided with information to understand why they're in the center. So we want to be able to explain to a child in language that they understand how long they're going to be in the center for, what steps are being taken to reunite them with their family if they're alone, or what steps are potentially being taken to help them place them in an alternative care family. So maybe a caseworker is working with a child to see if they have any family members they want to live with or that they typically live with. And if not, then looking at kind of other options we can explore. And we want as much as possible for children to actually participate in the decisions that affect them. So with that example, we always start with a child, asking the child, who did you live with before? You know, is there a reason you're not living with this person now, or that you're in the quarantine center, for example? Can we go to the next slide, please? Great. And we've gone through these first 2 points, but also just to highlight that we might need to make specific accommodations to meet the needs of individual children. And this could include children with disabilities, but it also could include other marginalized groups. And it's acknowledging, I think, there's this potential misconception or risk that we just consider kind of adolescents or children as smaller versions of adults, but that they actually really have specific developmental needs. So if there is a child on their own in a quarantine center, that we're actually providing one-on-one attention to them and making sure that they know where to potentially report complaints and what's happening with them. And lastly, we really advocate that infants and small children are not placed in quarantine alone without their caregivers or someone known to them. And this is because in this young age and developmental stage, the impact of not being with a caregiver is so significant that we always try to advocate for another option and for family-based care. Next slide, please. So a few additional scenarios that we might come across in a quarantine center is we might see that a family is placed together in a quarantine center. And if a family or a child has to go to a quarantine center, ideally this is the scenario we would hope for, that they would be able to go with their family and stay within that care. What we might want to do is just identify if these families will need additional support once they leave. So maybe there's an at-risk family member, or maybe there's a protection concern that's coming up. So we might need to consider providing case management, and that's child protection case management, to families once they leave the quarantine center. We might also see that maybe a mother comes with her child, or a child has to quarantine, and they've sent a cousin along to take care of the child because the mother needs to remain home to care for the other children. And this is fine as long as we have it documented that and that the person providing care for the unaccompanied child is over the age of 18, or sorry, the child is over the age of 18. So we want to make sure that they've been selected by the caregiver, they've agreed and they understand the kind of roles and responsibilities that they'll have in the quarantine center and that they cannot leave most likely. And then ensure that they're over the age of 18 and consenting. And of course, we want to record all contact information for the primary caregiver to make sure that if we need to, we can contact the primary caregiver. And then another scenario might be that we see a member of family placed in the quarantine center. So this is potentially that a caregiver gets put in the quarantine center. And so we want to ask and document caregiving responsibilities of family members prior to the admission into the centers. And then we recommend to contact the social service workers for children at home that may need support while the family is in quarantine. So this links to that question about, have you ever been worried about who is caring for the children? And with this, we recommend that you speak to the caregiver, ask if they have other children at home and who's taking care of them. And if it's someone under the age of 18, or if the children are being left alone, then this is an opportunity to contact the child protection social service workforce in that context or country to link them to those services. And that could be government social workers, it could potentially be an NGO that's working there, etc. So it's understanding those referral patterns and referral pathways. So we're now going to look at scenarios for isolation treatment centers. So the idea of quarantine centers being a place where you might be symptomatic or potentially have been in contact with someone with COVID-19 and having to quarantine. And isolation treatment centers is the idea then that further medical attention is needed. So you actually require medical attention now that symptoms have turned into something more serious. If we could please go to the next slide. And it's worth saying that I know isolation treatment centers have different names in different contexts. So it's really just thinking of the idea that we're separating people who are sick or are confirmed to have COVID-19 for the purpose of treatment or decreasing the risk of infection transmission. So in this scenario, if an unaccompanied child comes to the health facility and they are symptomatic and need treatment or have tested positive for COVID-19, these are the key actions that we would want to ensure. So we would want to make sure that the Child Protection Authority or actors are made aware of this child coming in. As soon as a child protection actor knows there's an unaccompanied child, kind of the sooner they can start to find an appropriate care placement. So we really recommend that as soon as you receive an unaccompanied child, you contact the child protection authorities. In some contexts that we've worked in, we have kind of a bank of potentially foster families that are trained and ready to receive children. And in other contexts, it really takes quite a lot of work and advocacy and coordination to make sure that we find the right family. So the more time, the better. If the child is brought to the center by an adult not known to them, so this might be kind of that example from Bangladesh, then we want to record the relevant family tracing and reunification information from that person. So this would be kind of recording where that child was found, and then ensuring that we keep all of the children's belongings, because this helps child protection actors to start kind of the investigative work of trying to find their family. The guidelines include 2 annexes that are relevant for this. One is an example of what this may look like, and the second is a form to fill out so that health actors know all the information that they should be gathering. And we've seen in the past, I mean, we've had in kind of different circumstances, potentially a baby that's kind of dropped off at a health center. And it is possible to do family tracing and to start that process. And the more information we have, the better. So kind of using that form in the guidance document to gather all that information so that we can go back and just start to put the pieces together. And one really important point that we've advocated for is to not discharge an unaccompanied child without the relevant authority or child protection actor present. So really advocating for procedures that have the right authority there, that they can support the child, because the unaccompanied children are at much higher risk of exploitation, and we don't want to run the risk of this being an opportunity if a child is released and there isn't kind of a follow-up mechanism in place. Next slide, please. So the last 2 scenarios that we'll go through is if a caregiver brings the child to the health facility. So this is what we were discussing a bit before, is that we want to discuss with the caregiver and the child the options. In some contexts, this is not even a discussion because the child has to enter without the caregiver if it's more kind of intensive treatment, if they need to go on oxygen, etc. But if there is an option for the caregiver to come with the child, these are kind of what we recommend. And there's also an annex that pulls out all this information so that health workers can have this discussion with caregivers. And so what we say is that they might say, okay, I can enter the facility with my child, that's not a problem. If that is the case, we would want to think about the children that they might be responsible for caring at home, and if there's an alternative caregiver there. The caregiver might identify an adult relative who isolates with the child or goes into the center with the child. So this was the example before of potentially a cousin or someone that goes instead of them. And it might be that this isn't an option and that the child has to actually enter alone into this health facility, in which case we would want to discuss who's going to take care of that child and how can the family member maintain contact with that child while they're in the health facility. And lastly, and kind of devastatingly, we've had scenarios in which children come with their caregivers, and the caregiver dies in the health facility. So this is kind of this extreme scenario that we hope doesn't happen often, is why we need to gather information from the time the caregiver enters a health facility. So we want to make sure that in them entering, they've identified an alternative caregiver. So if something were to happen to them, who should we call? It's kind of that emergency contact. If they've put down a name and we've got that recorded, then we verify the relationship. So we make sure they are who they say they are, and call the right people. And then it's our responsibility to see, do you know that you were put down as an alternate caregiver? And are you willing and able to provide care for this child? We never want to put the child in the care of someone who is neither willing nor able to provide care. And then we have to explain to the child what's happened. And there's guidance for how to do this in a child-friendly way, depending on the age of the child. Of course, it has to be contextualized with different terminology and approaches. If it's possible, we recommend to do this with a supportive adult or an alternative caregiver present, so that the child has someone that is maybe potentially a bit more familiar with them to provide that support system. If we didn't take this contact information at the start, then what we do is recommend to contact the relevant child protection authority or actors. So again, we need it, or if we're unable to verify, if this person says, actually, no, I'm not willing, I'm not able, or I didn't know I was put down as the alternate caregiver, then we contact the authorities to make sure that the right procedures are in place for that child to be in a safe care and to be followed up with. So these are kind of the different scenarios we've seen, and the key actions we recommend for health practitioners. We thought it might be helpful, now that you've kind of been spoken to for a while, to actually put this in practice. So we can go, great, thanks, Ryan. So we want to remember, in this scenario, just to remember a few of our key points. If we could go to the next bullet points. Great. So our key goals, this is very, very simplified, but if it's possible and if it's safe, our goal is always to keep family members together. If it's not possible and they have to separate, then we really want to maintain contact with the caregiver. This seems simple, but we've spent a lot of time advocating for phones, advocating for phone credit, making sure we've got up-to-date contact information, finding safe ways. I know in some contexts there's plexiglass put up to make sure that family members can still communicate but not run the risk of transmission. We want to make sure that we're listening to the child and the caregiver and that they can make informed decisions. So explaining what's the situation going to be like in the quarantine center or the health facility, how often will you be able to see them, etc., so that they have all the information to make the decision for them and their family. We like to think and say that families or people are kind of the experts of their own lives. So it's our responsibility to provide information and their responsibility to then make the informed decision and for us to facilitate that in the most safe way possible. And lastly, all children require care. So if a child is left alone, then we need to consider who can provide care for them. If that's a child with a disability, if that's a 16-year-old boy who might potentially kind of culturally be considered a man, we need to ensure that we've got kind of follow-up with children. So what I'm going to do is we're going to go back to that Menti link. So it's the same link that we can put back in the chat box, or hopefully it's still open on your browser. And I'll read through a scenario and then ask for you to vote what you think the action should be. Okay, so in our scenario, we have a community health worker who is going door to door to do COVID-19 prevention awareness raising. And they come across a female-headed household. The mother's name is Sarah. She's a single mother, and both her and her child have asthma. So she's caring for two children. One is Mo, he is 2 years old, and the other is her niece, and her name is Gan, and she's 14 years old. So just to recap, a health worker is in a community. They have come across a family where there are 3 people. Sarah is the mother, and she's living with Mo and Gan. Mo is her biological 2-year-old child, and Gan is her niece. And Mo and Sarah, so her and her child, have severe asthma. So the question is, should the community health worker refer this case to child protection based on the information you know? Right, I'm seeing votes come in. And I know some people prefer to read the scenario, so I'm going to also copy paste it into the chat box and give it just a few more seconds for people to vote. Okay, so our options here are, yes, the community health worker should refer this case to child protection because there's a potential risk of family separation between Sarah and her children because Sarah has asthma, severe asthma. Or the second option is no, they don't need to be referred to child protection. There isn't a risk here. And they've agreed to isolate, so there's no problem. And then the last one is yes, because Gan should be taken back to her family. So Gan is the niece, so she should be back with her potentially biological mother and father. Okay, great. Great, this is fantastic. So I'm really glad to see no one's voted yes because Gan should be taken back to her family. I think it's easy to eliminate this option because Gan is being cared for by Sarah. So we don't have any reason to take her away from that family. And this community health worker wouldn't be asking follow-up questions. Why is she living with you? How long has she been living with you? That's not necessary. So, so that's great. Yeah, we wouldn't want to separate Gan. There's no need to do that right now. And I think the spread of yes and no is really interesting. So there is a risk here of family separation. We would consider Sarah at a high risk if she has severe asthma. So it might be that we say, let's just refer to child protection to be sure, to make sure that if Sarah, for whatever reason, does end up having to go to a health facility, there's a backup plan for Mo and for Gan. And the other option is no, they don't have symptoms now, so it's not necessarily an issue. We don't really need to worry. So this will depend kind of on the context, but if we have the availability of child protection actors to go follow up, we'd say, yes, go follow up. It's a high risk case. Let's just make sure that, that there's an option. And I'll say that in a lot of our work in child protection at the start of COVID-19 was going to families and saying, do you have a backup plan? And high risk families, we weren't going to every family. And also going to foster families and saying, are you still willing to care for this child? If something's going to happen, kind of what are the other options? Great. So moving on in our scenario, but we won't move to the next question just yet. The community health worker, they decide actually they're going to do what most people here have suggested. They're going to refer the case to child protection. And a child protection caseworker comes to follow up with the family. And when she comes to the home, she realizes that none of them are there because they've all been moved to a quarantine center. They've been identified as being in contact with someone with COVID-19. And Sarah and Mo have subsequently developed symptoms. And just to remember, Sarah and Mo are the ones with asthma. And they're going to be referred to a hospital. So Sarah and Mo are going to go to the hospital. Our question is, what are the main health and child protection concerns for GAN now? So they're all in the quarantine center, and Mo and Sarah are going to the hospital. What are our main concerns for GAN? And again, for those who prefer to read the scenario, I will put it in the chat box and give some time for people to brainstorm and select one of the answers. Ryan, I see that people are voting, but we're not able to see the... Great, thank you. Fantastic. Okay, great. So the health worker has gone, they found that they're not home anymore. They're all in the quarantine center, and actually the situation's worse for Mo and Sarah. They're going to go to the hospital. So Mo is remaining with Sarah. We're less worried about family separation there, but now we're worried about the concerns for GAN, who might be left behind. So great. Okay, so our main concerns that we're seeing is GAN will be separated from her caregiver, Sarah. So if Sarah and Mo are going to the hospital, where is GAN going to go? Unlikely she'll go to the hospital as well. GAN will be left alone in a quarantine center as an adolescent girl. This is a risk that we might be seeing. And if Sarah's situation deteriorates, so now this is Sarah and Mo may be left alone or at risk of witnessing distressing events. So maybe we say, okay, we're not that worried about Mo and Sarah at the moment because they're together, but actually what happens if Sarah's situation deteriorates? So these are all concerns that we're starting to brainstorm and think about in our kind of child protection lens and our child protection head. Great. So then the question is, what are our priorities for GAN now? And we can go on to the next question and we'll see some options. Great. Wonderful. So people are already voting. So we've got a couple of options. And the question is, which one would you prioritize? Would you send GAN home to be in a comfortable environment? So Sarah and Mo are off to the hospital. GAN is now at risk of being left alone. Where should she go? So should she go home to be in a comfortable environment? Should we identify a trusted community member that can care for GAN? Should we move GAN to the hospital to be with Sarah and Mo, keep them together? Or should we explore if GAN's parents or another family member can care for her? Okay, great. And I have to say, all these, this is a fictional case and scenario, but this is very much based on reality. So we see these questions come up. Great, so I see most votes have gone to explore if GAN's parents or another family member can care for her. And this is great. We want to first see what are the family-based care options. And GAN's 14, so we can likely ask her and speak to her. Do you have parents that are willing to care for you? Do you have another family member that you prefer to be with? And then we do that, while keeping Sarah informed and having her perspective on who GAN should live with as well. And I see there's a couple of votes on move GAN to the hospital to be with Sarah and Mo. If this is an option in the context, we'd want to explore it with GAN and Sarah and see if that's something they want. Of course, we'd have to weigh that with the risk of, if GAN goes to the hospital, are we putting her at greater risk of infection? So it's balancing these decisions. And I see a vote for send GAN home to be in a comfortable environment. And I think this one's a bit of a trick answer because yes, we want GAN to be home, but we want her to be with someone who can care for her as well. Great. So now our last component to the scenario is Sarah and Mo are in the isolation treatment center. and Sarah starts to stabilize. And it looks like she can be discharged. But Mo's situation gets much worse, and he has to go to the next level of care and receive oxygen. So the question is, what key pieces of information do we need to decide how we move forward? Now we'll put that in the chat box and just recap. And you can choose multiple options with this. So Sarah, we've got Gan living with a family member, we're happy, but Sarah and Mo are in the hospital or in the isolation treatment center, and Sarah stabilizes, but Mo is getting much, much more sick. So Sarah is the caregiver and Mo is the child, and Mo has to go to the next level of care and receive oxygen. So the question is, what key pieces of information, what are the key pieces of information we need to decide as we move forward? And the options are, we need to understand if Sarah can go with Mo and if she wants to. We need to consider who is caring for Gan and if Sarah has been in contact with her. We need to consider how Sarah can stay in touch with Mo if he is admitted alone. And we need to consider what types of care and risks are present in the ITC. Okay, great. It's a very even spread. Fantastic. Okay, this is wonderful. And it's exactly this. We kind of need to be considering all of these things at the same time. We need to understand if Sarah can go with Mo and if she wants to go with Mo to the next level of treatment. We need to make sure that Sarah is still in touch with Gan and that Gan is still happy in her placement and Sarah is still happy with where Gan is for the time being. If Sarah says, actually, I have a job, I have to get back, I need to take care of Gan as well, I can't go with Mo, or I have asthma, it's too risky for me to go, then how can we help Sarah to stay in contact with her child while he's in the ITC or the hospital? And we need to consider what types of care and risks are present. So these are kind of informing all of our decisions, medical risks, protection risks, etc. So great, I think you're all got your child-focused lenses on. This was really fantastic, thanks. So we can go back to the PowerPoint. And we've got 2 minutes to spare. We wanted to allow an opportunity if anyone wants to ask questions in the chat box. Knowing that we have 2 minutes, we can see how many we can respond to, or we're more than happy to take these offline and provide responses after the fact. Please do feel free to type in any questions or come off mute if you'd like to ask a question.
And just to say that there is a lot more detail within the guidance itself. So if you want to, please do look at the guidance after the session.
Great. Well, if you do come across questions as you're, I hope, reflecting on these guidance or these guidelines, do feel free to reach out. I've got my email address there and I'm happy to respond as well to kind of questions that come up for specific contexts.
Lori, there's a quick question about what kinds of information, how would we verify the identity if we're trying to do a verification for reunification? What kinds of things would we ask or use to verify that the person is the person that they said they would be?
Yeah, so there's a couple of things we can look at, and we often think about, so we ask the parent and the child the same question. So when did you separate? Where was your home? What was the last thing you were wearing when you separated? So we're just trying to align that the information is the same. What we also do sometimes is take pictures of people that kind of fit this, the description, and have the parent and the child flick through and say which one is their child or which one is their parent. And it's a really, really important process before we reunify family members. Becky, I don't know if you have anything you wanted to add to that.
No, but it also just depends on the age of the child. Certainly if the child knows the caregiver and can help with that knowing who that, you know, have a picture or something of that the child can verify as well. It is
Great.
harder when they're younger, yeah.
Yeah, absolutely. All right, I see we're 1 minute over. So thank you so much all for joining. And we hope you were able to take something away from this. Do let us know if you come across questions or have any additional comments. Thanks so much.